Hello, class, and welcome to Diverse Populations. My name is Dr. Neil Soggie, and I am your instructor for this course. I want to welcome you to ADC 244. This course is really designed not only to educate, but also to challenge and expand the way we understand addiction and healing and human diversity in our work as future counselors. So we gather here not only as students of counseling, but also as learners embedded in specific communities and histories and identities. And that's especially significant here at SWCollege, where we are situated on the ancestral homelands of the Dakota people. So as we begin this course, let's just acknowledge the land and recognize that the work of culturally competent and exclusive counseling is, at its roots, about restoring relationships with self, with others, and with the cultures and contexts that shape our lives. This is a really interesting course in that we explore how race and ethnicity and gender and sexuality and addictions and historical trauma shape lives and impact healing. And it also looks at how we can critically examine our own values and beliefs and assumptions in relation to the people that we serve, and how to apply culturally responsive counseling theories and practices to real-world situations involving often marginalized peoples and populations. So our goal here is not to simply memorize terms or replicate techniques. Our goal is to become professionals who practice with integrity and humility and cultural respect. Because research consistently shows that cultural responsiveness improves treatment engagement and outcomes and client satisfaction. So we begin our journey today by examining the concept of cultural competency, which is, a term that's often used but rarely unpacked with the depth that it really deserves. So hopefully by the end of this lecture, I want you to be able to explain what cultural competence is and understand why it matters in the addiction and mental health counseling field, and begin to identify your own place in the cultural competence continuum. And this is the foundation, really, of everything else that we'll do in this course. So take a moment, get comfortable in your space. You are part of a community of learners who will help to shape the future of mental health and addictions care. And that future must be one of integrity and inclusion and care and love and deep cultural understanding. So as we begin this lecture, we're going to explore, as always within my classes, I like to start by telling a little story about a person who has, in their lives, contributed much to the field. And then we'll get into the three main themes. The themes for today, the first theme will be looking at how we can define and understand the evolution of cultural competency in the counseling profession. And we'll begin by clarifying what we mean by cultural competence, That word is used so widely, but oftentimes it's misunderstood as simply being nice to people from different backgrounds or knowing about holidays and food customs. But in reality, cultural competence is much more complex. It's about a complex integration of awareness and knowledge and skills that really enable a counselor to provide ethical and responsive and effective care to clients from diverse cultural backgrounds and social situations. And it includes, but not limited to, the counselor's awareness of their own cultural identity and their own biases, knowledge of other cultural worldviews, and clinical skills that adapt treatment to the client's context. So you'll see in there that this course isn't the end all and be all of cultural competence. It's really getting you started on that journey. And cultural competence really emerges in response to the Eurocentric counseling models that really historically have ignored or misinterpreted the experiences of marginalized clients, including Indigenous peoples and immigrants and communities of color and LGBTQ plus individuals and others. And you'll notice in there, even in my language, it is biased in many ways. So we'll trace this historical evolution from the civil rights era to today's emphasis on cultural humility and highlight the limitations of early models that framed culture. It used to be just a checklist rather than a relationship, and hopefully we can move beyond the checklist idea. The second theme I want to explore today is understanding ethical and clinical importance of cultural competence practice. So we'll look at what is the core ethical and clinical requirements in addictions and mental health care. And hopefully this will increase your client engagement and treatment retention and reduce misdiagnosis and improve long-term recovery outcomes. As the American Counseling Association Code of Ethics states, that counselors need to gain knowledge, personal awareness, sensitivity, and skills pertinent to working with diverse client populations. So in the context of substance use counseling, failure to do so can lead to relapse and re-traumatization or disengagement, especially when clients feel their cultural identity is misunderstood or minimized or pathologized. And then we come to theme 3, the cultural competence continuum, something that's been widely used and really kind of defines 6 stages of cultural responsiveness, from cultural destructiveness to cultural proficiency. And so we'll look at where are you currently in your journey, and where do you want to go as far as culturally responsive practitioners, and what are the concrete steps that we can take to move forward in this. So, in understanding these terms, hopefully it'll help you to begin a shared language that when we come to our future lectures and discussions and assignments, that we are all on the same page. Now, want to begin by telling you a story about Dr. Daryl Wing Su, born in 1942 in Portland, Oregon. He's a second-generation Chinese American who became the professor of psychology and education at the Teachers College in Columbia University. And in his field, focuses primarily upon cross-cultural psychology and racial identity development, as well as microaggressions and multicultural counseling. Now, his early life was one that was shaped by experiences of racism and cultural invisibility, both personally and academically. And he has written about how his early psychology training completely ignored the experiences of people of color, and how the dominant models of therapy were based upon white middle-class male norms and did not account for different communication styles and worldviews or historical traumas experienced by racial minorities. And this exclusion sparked a lifelong passion to challenge monocultural models in psychology and develop theories that embrace racial and ethnic and cultural diversity. So, as a professor at Columbia University, he contributed many things. One of the first things that he did is, along with colleagues Patricia Arredondo and Roderick McDavis, developed a model for basically the multi-dimensional model of cultural competence, which really kind of became the cornerstone of multicultural counseling and training. And there's kind of three main components of cultural competence along these lines, and that was the idea of awareness, that is kind of understanding one's own cultural identity and one's own biases and values. Then knowledge, and basically this means gaining accurate information about other cultures. And then skills. And here they kind of talk about developing and applying culturally responsive strategies. He also did some work on racial microaggressions. So back in 2007, he had an article that was very interesting that defined and categorized the idea of racial microaggressions, which are really subtle, often unintentional comments or behaviors that insult or invalidate or marginalize people. You know, like for example, asking an Indigenous person if they live on a reservation might imply that they're not part of modern society, although hopefully that's not the case. And his taxonomy of microaggressions has been cited over 10,000 times and really kind of remains essential to cultural competence practice, particularly when counseling marginalized clients who are navigating everyday racism. And he also became the author of a work known as Counseling and Cultural Diversity. And it sold hundreds of thousands of copies across the field of counseling. And he's also done a lot of work in shaping and training and practice in the American Counseling Association, as well as the American Psychological Association. And so his models have become very important in substance use treatment programs, particularly those funded by the Substance Abuse and Mental Health Services Administration. He's also won a number of awards for the APA, for the American Psychological Association Lifetime Achievement Award in Multicultural Psychology and the Distinguished Contributions to Education and Training. Now, part of his legacy is that whole idea of diversity and understanding the racial and linguistic backgrounds of clients in order to care for them in a culturally responsive way, which I think is very, very important. So, in your work and in your research, if you come across Dr. Sue, really do appreciate his work. Now, let's dive into cultural competency, because that's really the core of this lecture. And when we talk about cultural competency, we're talking about the ability of counselors to work effectively and ethically across diverse cultural contexts. And so this includes understanding one's own cultural background and biases, acquiring knowledge about different cultural practices, and developing therapeutic skills that adapt to the cultural context of the client. Now, a widely accepted definition comes from Cross and Vanson and Dennis and Isaacs, which basically says this: cultural competence is a set of congruent behaviors and attitudes and policies that come together in a system, in an agency, and among professionals, and enable that system and agency and those professionals to work effectively in cross-cultural situations. So, hope you see in there something. Cultural competence is not a one-time achievement. It is a dynamic developmental process that requires continuous growth and humility and engagement with structural inequalities. So why does it matter in mental health and addictions? Well, it's because mental health and substance use problems don't exist in a vacuum. They are shaped within cultural values and norms and traumas and languages and spiritual beliefs and family systems. And so culture is going to determine how we express our symptoms, how our client's addiction is understood. Is it sin or illness or an imbalance? How we trust a healer, and whether that be a spiritual healer, a counselor, an elder, or a medical professional, and what kind of stigmas are attached to the help-seeking behavior. So, when counselors fail to consider culture, they risk misunderstanding the client, alienating or offending the client, using interventions that conflict with their values, miss opportunities to build on cultural strengths. And in contrast to that, when counselors are culturally competent, research shows that client satisfaction and retention increases. Treatment outcomes for substance use recovery improves. And disparities to mental health access reduce. So, what is cultural competence? Well, there are those three intersecting domains of awareness, that is, understanding our own cultural identity and our power and privilege and positioning in the counseling relationship, and historical traumas and colonization and oppression that's been experienced by marginalized groups. And then the knowledge of cultural traditions and health beliefs and communication styles, and then the skills to adapt counseling techniques to fit the client's worldview, to use culturally appropriate assessment tools and metaphors and interventions, and to use culturally inclusive language, and to try to avoid, on a continuous basis, microaggressions, and integrating traditional and spiritual practices that are desired by the client. Now, research has shown that, for example, marginalized indigenous knowledge systems would be very useful when incorporated in counseling into ceremony and oral traditions and community-based models. And that can help to enhance cultural safety and efficacy. So, in essence, cultural competence is not a checklist. It's a process of becoming. It's something that we continue to become as we become better and better counselors and develop our own authenticity as caregivers. So, to understand why cultural competence is foundational to contemporary addictions and mental health counseling, we really need to examine where it comes from, historically, and politically, and academically. So, back and really kind of throughout much of the 20th century, mainstream counseling and psychology in the U.S. were grounded in Western white middle class norms, male norms. And so theories of normalcy and health and pathology or sickness were based on very limited cultural samples. You know, we have people like Freud and Rogers and Skinner that developed models with little attention to race and class and colonialism or culture. And while these theorists are good, they're limited. And the frameworks that they exported through institutions and taught universally can be weak. Things like, simple direct eye contact or individual expression of emotion or autonomous decision making really reflects Western cultural norms and pathologized clients whose behavior diverged from that framework. And we need to kind of be mindful that not everybody comes from that background. That's not normal for everybody. That there are many communities where other expectations are what is grown up. So the civil rights movement, along with the American Indian movement and the Chicano movement and the rise of LGBTQ and feminist advocacy, really kind of began to influence how mental health professionals viewed power and privilege and inclusion. And scholars began questioning the implicit racism and ethnocentrism embedded in things like the diagnostic systems and treatment protocols and academic research. So in the 1970s, community psychology really started to take off. And this was tied very closely to the Association of Black Psychologists, which was founded in 1968, and other affinity groups that really wanted to develop culturally specific mental health models. So you have scholars like Joseph White and Linda Myers and Eduardo Duran that started to develop frameworks that were rooted in indigenous-centered psychology or Afro-centered psychology. And these different frameworks really resulted in reframing how we think of healing and trauma and identity. And so this began to be formalized then in the 1980s and 1990s, and the term cultural competence really started to come to the fore. There was a paper that was presented that really kind of brought this forward called Cultural Competence Continuum. And in 1992, Dr. Su, who I've already mentioned, along with his colleagues, introduced that multidimensional model of cultural competence. And we've talked a little bit about how that kind of is built upon that tripartite domain of awareness and knowledge and skills. And so this started to become integrated into the clinical effectiveness and ethical conduct of counselors. And then in the early 2000s, accrediting bodies like CACREP, which is the Council for Accreditation of Counseling and Related Education Programs, as well as the APA, the American Psychological Association, required cultural competence to be embedded into counseling curriculum. And so from the 2000s to today, we have seen a movement that recognizes that competence implies a fixed skill or endpoint. That's not really the case. It's more about improvement, constant improvement. And we don't want to just reduce culture to a set of facts, but to understand the dynamics of competence and of culture. And so it's about continuously engaging in cultural learning, not simply relying upon knowledge already required. And so again, this course is kind of getting us started on that process, laying a foundation. It's not the end point. It should never be the end point. When you're working with people, people change, people grow, cultures change. We need to continually be growing and developing and learning. But at its core, what we can do is understand better historical traumas, to recognize that Western treatment models often fail to incorporate spiritual and communal dimensions of healing. That cultural competence approaches can incorporate, in the Indigenous context, sweat lodges and storytelling and kinship systems and land-based healing, not just sobriety. So I hope you see there that appreciating the culture of healing and how history has evolved in this field kind of invites you along for the journey so that you too can be a part of the transformation process. The other thing I want to kind of highlight is that cultural competence is not a peripheral issue in addiction treatment. It really is central, and research is clear that treatment that does not account for culture can fail to engage clients and misinterpret symptoms and reproduce harm, especially among historically marginalized groups. So addiction is cultural, not just chemical. Mainstream addiction models, especially those that evolved out of early 20th century medicine and mid-century behavioral psychology, often framed addiction as being purely biomedical or behavioral. It's a disease of the brain or a problem of poor choices, and that's it. But life is much more complicated than that. And so the model that we have historically used ignored the rule of things like social oppression, colonization, racism, poverty, cultural dislocation and identity loss, spiritual emptiness and historical trauma. But when we recognize and respond to cultural disruptions and community disintegration and intergenerational grief, we can help our clients so much better. There's a lot of research evidence that cultural competence improves outcomes. There's been some a meta-analysis, for example, from 2006, looked at 76 different studies, and it showed that culturally adapted mental health interventions were significantly more effective than non-adapted ones. And the effect was strongest when the treatment matched the client's cultural identity and values. And there's been lots of studies like that. And when we look particularly at Indigenous scholars, they will argue that addiction in Native communities is best understood as a symptom of cultural disconnection, resulting from things like boarding schools and outlawed ceremonies and loss of language and broken kinship systems. It's kind of what some scholars have called, particularly Eduardo Duran, has called the soul wound. It's a collective and historical trauma that resulted from colonization, and healing must therefore include reconnection to traditional life ways and spirituality and intergenerational belonging, not just detox and abstinence. Similarly, LGBTQ and Two-Spirit Indigenous individuals have faced dual marginalization. So we need to kind of be mindful of the different ways that people are marginalized and hurt by particular models. And we need to also remember, I think, that counseling is relationship, and culture shapes relationship. So at its core, counseling is relational, and culture shapes how a person trusts and discloses vulnerabilities and expresses pain and relates to authority and defines recovery. So cultural competence simply allows counselors to enter the client's relational world. And that's the core of counseling, to enter the client's lived world and to explore that world and to help that world to find healing. Now, let's take a little bit of time and look at the cultural competence continuum, because it's really foundational. It's something that was developed by Cross and Banzan and Dennis and Isaacs in the late 1980s. And as I mentioned, it is a developmental process. It's a spectrum that ranges from cultural destructiveness to cultural proficiency. Stage 1, cultural destructiveness. This is obviously the most harmful position on the continuum. It includes active denial and devaluation of other cultures, policies or practices that intentionally harm or erase cultural identities, a belief in the superiority of the dominant culture. And historical examples of this include things like boarding school systems for Native American children who aim to kill the Indian and save the man, as a quote has been. And practices that pathologize cultural behavior, like diagnosing spiritual ceremonies as delusions. So in modern counseling, hopefully, this may show up as, not hopefully, but hopefully we avoid this, is what I'm trying to say. Stage 2, we can move hopefully from that destructive stage to stage 2 and towards higher stages as we grow and understand. Cultural 2 is cultural incapacity, which is less overtly hostile, but still pretty damaging. It really is a lack of capacity or awareness or skill to interact across cultures. It's very paternalistic in its attitudes and rooted in stereotypes. There's a lot of unconscious bias and systemic discrimination embedded in the practices. So, for example, a treatment program might accept Indigenous clients, but insist that they conform to a strict Western 12-step model, without room for traditional healing or spiritual flexibility. And this failure to accommodate isn't overtly malicious, but it really is neglectful. Then there's stage 3, cultural blindness. And this stage is common among well-meaning counselors and institutions. And this includes the belief that treating everyone the same is the fairest approach. Now, it refuses to acknowledge differences in culture and power or access. And so when you say, I don't see color, I just see a human, you're really trying to be inclusive, but you're ignoring the reality of lived experience, especially among clients who have faced historical trauma and racism and language barriers or cultural disconnection. And so it prevents clinicians from tailoring care in ways that actually meet the client's needs. Stage 4 is where we're kind of moving towards competence, but it's kind of pre-competence. Here, at least, we recognize that the organization or individual lacks cultural competence, and there's a willingness to learn and self-reflect and improve. So this stage at least requires honesty and a commitment to cultural humility. Then we can move ideally to stage 5 of cultural competence and demonstrate the awareness and knowledge and skills needed to interact effectively across cultures. It's about being proactive in adapting our practices and our materials and our policies to reflect cultural relevance. It includes ongoing training and consultation and collaboration with diverse communities. So it's about offering multiple languages. It's about integrating traditional Indigenous practices into treatment plans when they're appropriate. It's about advocating for equity and social justice within systems. It's about adjusting agency policies and advocating for funding for Indigenous-led recovery programs and pushing for systemic reform of behavioral health access. It's about being honest, essentially, and being self-reflective. And continually asking the question, where am I currently operating? Where on this continuation is my organization, my profession? Where am I on this continuum and spectrum? So when I think in terms of the tribal college context, moving toward cultural proficiency includes things like really focusing and centering on Indigenous worldviews of healing and relationality and curriculum and treatment models, and validating ceremonial practices as part of the recovery process, and training non-Native counselors to work as allies, not authorities, within Native communities. And this also means making room for Indigenous leadership and cultural language revitalization and land-based healing as legitimate and vital forms of addiction counseling. Now, I want to kind of highlight a little bit here as far as language. Because language shapes understanding. And in the counseling field, you don't get very far without using some technical jargon. But they always carry ethical and relational and cultural weight. So we kind of need to be mindful of that. So when we talk about cultural competence, we're really talking about is the counselor's ability to understand and respect and effectively respond to the cultural and contextual factors that influence the lives of clients from their diverse backgrounds. When we talk about cultural humility, this again is a lifelong process of self-reflection and self-critique, where we're acknowledging our limits of our knowledge, where we're actively seeking to learn from clients, and where we work to reduce power imbalances. And microaggressions. We need to recognize that microaggressions are brief, everyday verbal, behavioral, and environmental slights, whether we are intentional or unintentional with them, but they tend to communicate hostile, derogatory, or negative messages to people based on their membership in a marginalized group. And these can include micro-assaults, which are just overt slurs or discriminatory actions. They might be micro-insults, where we demean a person's identity, or micro-invalidations, where we diminish or demean or negate a person's experience. All of those things have an impact on a person's life. They undermine whether or not a person wants to continue with treatment. Dropout rates, it impacts that. It impacts understanding and undermines trust and safety. And a very negative thing is that it reinforces systemic oppression, which we don't ever want. So we need to kind of be mindful of the terms that we use as well. And that's something I always struggle with as well. So, looking at theories and models, that also matters. But they always need to be translated into real behavior. So I want to try to bridge the gap between abstract knowledge and clinical action when we explore these kind of things, when we're learning about cultural competence and humility and microaggression. So I want to just kind of take a moment and just kind of think about this. Dustin is, let's say he's a 28-year-old. He's Dakota, and he's referred to outpatient addiction treatment after multiple arrests related to alcohol use. He arrives late to group therapy. He avoids direct eye contact and rarely speaks unless prompted. When he does talk, he references things that happened to my grandma and makes comments about white man's therapy and how it doesn't work. Now, a standard clinical interpretation of this might be that Dustin is being defiant and non-compliant and lacks motivation for recovery. And so there might be, some negative comments made around this. But it ignores certain cultural things that we need to kind of be mindful of. Plains indigenous cultures often use indirect speech and nonverbal communication and silence as a sign of respect. There is historical trauma there. Being forced into assimilation, medical abuse, and broken treaties. That's a real thing. And relational worldview of Dustin, recognizing community and ceremony and spirituality rather than group talk therapy. So, a culturally competent counselor can respond by affirming the client's worldview, by opening up the space for collaboration, for demonstrating humility and respect rather than authority. And that can go a long ways to help Dustin work through some of the challenges that Dustin might be facing, and help Dustin to define his own journey of healing. Now, one of the most common and often harmful mistakes counselors make when working with culturally diverse clients is cultural blindness. The refusal or failure to recognize how culture and history and context shape a person's behaviors and beliefs and expressions of distress. And cultural blindness operates under the assumption that all people are the same and that it is fair or even ideal to treat clients identically, regardless of their cultural identity or social experience. And while often rooted in good intentions, this approach leads to clinical errors and broken trust and missed opportunities for healing. So, let's take Jose, who's being evaluated by a clinician. Jose's 17, a Mexican-American male, comes to his school counselor due to some behavioral challenges. He's withdrawn, he's failing class, and he's seeing his grandmother, who's deceased, and feeling her presence at home. And so he lights some candles and speaks to her photo at night. And so in the referral, it's talking about talking to the dead and social isolation and declining academic performance. And so they're looking at psychosis. And if you're just looking at this from a DSM perspective, the Diagnostic and Statistical Manual, without any cultural training, you might be thinking hallucinations, magical thinking, possible delusion. And so you just prescribe Jose antipsychotic medication. But just wait a second here. That just is textbook cultural blindness. Maybe this symptom is actually a spiritual practice. In his community, as well as many communities, and particularly in his community with a strong Catholic influence, Mexican Catholic influence, ancestor reverence is sacred and culturally normative. It's a normal practice. The whole idea of the Day of the Dead, the rituals around that, it's not a clinical disorder. It's a misunderstanding of a underused practice. And so if there was cultural competence in that context, the client might simply ask, can you tell me about your grandmother? What does it mean to you to light candles and to talk to her? And this question shows openness and respect. And then the counselor might explore things like, is this something others in your family do? Does it bring you comfort and peace? And how does your community talk about the dead? And in doing that, ideally, if Jose's bilingual and the counselor's bicultural or bilingual, that's even better. But the thing here, I hope you see, is that it helps to misdiagnose what is really culture, rather than medicalizing culture, and we can adjust our understanding. Basically, what it teaches us is that cultural blindness is not neutral. It causes misdiagnosis, it causes treatment dropouts, it causes ethical violations. So a culturally competent counselor takes the time to ask, to listen, and to learn. So cultural competence is not just best practice. It is a professional, legal, and ethical obligation for anyone providing mental health or addiction services. Both the American Counseling Association and the National Association of Alcoholism and Drug Abuse Counselors, NADAC, clearly define expectations related to cultural awareness and respect and inclusion. And these codes emphasize that counselors must continually develop multicultural knowledge and recognize and address power dynamics in the therapeutic relationship and avoid imposing personal values or biases and advocate for culturally relevant services. Now, cultural competence takes a unique dimension when working with tribal nations, particularly in the context of addiction counseling. So I want to take just a few moments here and just kind of talk about this a little bit, because this is fairly important, particularly in our context. So where cultural disconnection and historical trauma and systemic oppression have played defining roles in both the development and addiction and the pathways to recovery, in the context of this course being taught at SWCollege College, it's especially important to understand that Native communities are not simply cultural minorities. They're sovereign nations with distinct political, legal, spiritual, and social structures. So we're not just talking about diversity, we're talking about embracing an understanding of tribal sovereignty and colonial history and trauma and indigenous epistemologies, the source of knowledge and healing practices. So I want you to be mindful of the long and violent history of colonization. That's part of working in communities, of understanding the criminalization of indigenous spiritual practices, of honoring the relational and holistic worldviews, the relational worldviews, the kinship networks, the spiritual guidance, the ceremony practices, and recognizing that land and language are powerful forces in a client's life. I also want to caution you just a little bit against cultural appropriation, particularly for us that are non-native counselors. Be cautious if you're a non-native about using sacred practices like smudging and sweat lodge ceremonies without tribal approval. Work with tribal authorities and with elders in those cases. Don't simply co-opt them. And that's something that I always need to be mindful of as well. Even growing up, being taught to smudge, I still need to kind of be mindful that that's something for myself individually, and when I'm working with clients, that I need to work with others in that context. It's also about recognizing that there are Indigenous-led models of addiction recovery. There's something called the Red Road of Recovery, which is a spiritual and cultural approach that emphasizes balance and respect and accountability and connection to the Creator and community. There's Wellbriety movement. There's community-based movements. And we'll talk about all of these. We'll explore these in greater detail. But when it comes to practical context for working in a tribal context, a few things for counselors to be mindful of. First off, learn the local tribal history. If you grew up in this tribe, don't simply assume that you know everything about it. Understand the treaties, the relocation events, the legacy of boarding schools. Ask respectful questions about culture and ceremony and language, and build relationships with community leaders and elders and cultural practitioners, and attend community events and trainings, and avoid deficit models. And as we come to close this lecture, I want to highlight 3 key terms. First, I want to highlight cultural competence. Remember, this refers to a counselor's ability to understand and appreciate and effectively work with clients from diverse cultural backgrounds. This involves awareness of one's own cultural worldview and biases. It involves knowledge of other cultural norms and histories. And it involves skills to adapt counseling techniques to clients' cultural contexts. We also need to be mindful of historical trauma. And what do we mean by historical trauma? It is that historical trauma is the cumulative emotional and psychological wounding across generations that is caused by massive group trauma, including colonization and genocide and boarding schools and forced assimilation and systemic racism. And it plays a key role in the development of addiction and mental health issues in Native communities, and we need to recognize that. And then finally, cultural humility. That is something that all counselors need to develop. It is a lifelong reflective process in which counselors continually examine their own cultural identities and remain open to learning from clients. and actively work to reduce power imbalances in the therapeutic relationship. Now, I always want to, in my lectures, have a question, and that question will make up part of the quiz. So my intention in doing quizzes is to make the testing side of the course short and simple and sweet. And so I just have these questions here because that inevitably these questions are going to be on your quiz, basically. So you basically know what's going to be on your quiz. If you engage in the material, if you study, you're going to do really well. But you have to actually expose yourself to the material. That's the key thing here. So in this case, which the following best demonstrates cultural competence in an addiction counseling session with a Native American client? And I would suggest that it is C, inviting the client to share how cultural and spiritual practices might support their healing process. Because that is a couple of things. First off, it invites relationship. It invites collaboration. It respects the client's worldview. And it opens up the possibility of integrating culturally meaningful practices into treatment without imposing assumptions or judgments. It enters the client's world and makes room for the client's culture, however that client understands it. And a few closing thoughts, if I may. Remember, cultural competence is not a technique. It's really about a commitment to being aware of our own biases and our own cultural lenses, of actively seeking knowledge in relationships across cultural lines, and above all, to practice counseling with humility, empathy, and accountability. It's about engaging in your responsibility to build ethical, culturally safe relationships where healing becomes possible. And so you ask yourself, what do I bring into the room as a helper? How might I not, what might I not know yet? And how will I find out respectfully what I need to know? And how can I let culture and story and tradition guide my work rather than just my training? Basically, how can I learn from the client as we move in this journey in exploring and healing the client's lived world? Hope you enjoyed this lecture, and I will see you next week. You take care. Bye-bye.